right now, there is a surgical robot that is capable of weaving 64 microscopic, highly flexible threads into a living, beating human brain.
Yeah, and it does it in just over a minute.
Right, in just over a minute. And it's doing this with a level of, like, relentless precision that is physically impossible for even the world's most skilled neurosurgeon to match.
It really is a complete inversion of how we normally think about surgery. I mean, the margin for error effectively disappears.
Yeah.
And the scale is almost impossible to comprehend without, stepping back and looking at the actual mechanics of it.
And that scale is exactly why we are taking you on this deep dive today. Because if you've been casually following the news, you know that the idea of connecting a human brain directly to a computer has officially crossed from science fiction into actual medical reality.
Definitely. But there is a massive amount of noise out there right now.
Oh, so much noise. So today we have a very specific mission. We are looking past the hype, and we are examining the hard clinical data of Neuralink's N1 implant.
Yeah, we need to look at the actual numbers.
Exactly. Our guide for this is a really fascinating piece from April 6, 2026. It's from the cross-disciplinary publication SpiralSeekr.
Right, the piece titled Neuralink and the Emergence of Brain-Computer Interfaces.
That's the one. We are looking specifically at how this technology is transitioning into high-volume production and automated clinical deployment right now in 2026.
Because it's no longer just a prototype.
Right. Okay, let's unpack this. Fundamentally, before we get to the robots and the threads, what is the N1 implant actually trying to do?
Well, at its core, the N1 implant is a brain-computer interface, or a BCI.
Okay.
And the primary purpose of this specific piece of hardware is to act as a bypass. So think about a severe spinal cord injury.
Right, where someone is paralyzed.
Exactly. In those cases, the brain itself is entirely healthy. It is still generating the electrical signals and the intent to, move a hand or a leg.
But the physical bridge, like the spinal cord that carries that signal to the limbs, is broken.
You've got it. So the N1 is designed to be a new digital bridge. It records that localized neural activity directly at the source, intercepts the command, and translates it.
But the way it intercepts that command is where the hardware gets pretty wild.
Oh, absolutely.
Like the SpiralSeekr source details that the N1 implant features exactly 1,024 electrodes, but they aren't sitting on a rigid computer chip like you might imagine, right?
No, not at all. They are distributed across 64 flexible threads.
And to visualize this, you have to think about something that is thinner than a human hair. These threads have to be implanted directly into the motor cortex of the human brain.
Yes, the motor cortex. And for context, that is a strip running essentially across the top of your brain that serves as the central command room for all of your voluntary movements.
Okay.
When you think about wiggling your fingers, that is where the electrical cascade begins.
But I want to push back on the design choice here for a second. Because why threads?
What do you mean?
Well, we build incredibly powerful, rigid microchips every day. Why are we trying to weave hair-thin threads into brain tissue instead of just, placing a tiny sensor on top?
That comes down to the physiological reality of the human brain. The brain is not a static object.
Right. It moves.
Exactly. It pulses with every single heartbeat. It shifts slightly when you turn your head. If you put a rigid piece of silicon, like a traditional chip, into a moving, pulsing organ, the friction causes a big problem.
The body fights back.
Right. The brain forms scar tissue around the rigid object, and over time, that scar tissue acts like insulation, and the electrodes go deaf.
Oh, wow. So they just can't read the signals anymore.
Exactly. The threads, on the other hand, because they are completely flexible, move with the brain tissue. They ride the pulse.
Which solves the scar tissue problem, but, it creates a massive surgical problem.
A huge one.
You are basically trying to push wet spaghetti into a gelatinous moving object. Which brings us to the surgery itself and that specialized robotic system we talked about at the top of the show.
Right, the sewing machine, as people call it.
Yeah. According to the 2026 statements from Neuralink's leadership in the source, this robot is currently transitioning toward full automation. And I have to admit, my initial reaction to this was totally skeptical.
Why is that?
Well, we have incredibly brilliant, highly trained human neurosurgeons in the world. People who have dedicated decades to the precise manipulation of brain tissue. Why take the human out of the loop?
What's fascinating here is the sheer mathematical reality of the physics involved. The source notes two very specific metrics about this robotic system.
Okay, what are they?
First, it achieves a single thread insertion time of 1.5 seconds. And second, it does so at depths exceeding 50 millimeters.
15 millimeters, wow.
Yeah, and a human neurosurgeon, no matter how skilled they are, is bound by human biomechanical limits. You have a resting heart rate, you have a pulse, you breathe, and you have microscopic tremors that are entirely natural.
So even the steadiest hand in the entire world is still attached to a circulatory system.
Precisely. Now, factor in the environment. The surface of the brain is covered in a dense network of tiny, vital blood vessels.
Which you obviously don't want to poke.
Definitely not. When you are going down past 50 millimeters, you absolutely have to avoid severing those vessels.
So how does a robot do it?
The automated surgical robot uses advanced optical systems to actively map the blood vessels, and then it dynamically adjusts the insertion path of the needle on a microscopic scale in real time.
For every single thread.
For every single one of those 64 threads. To do that perfectly while taking only 1.5 seconds per thread demands a relentless objective precision that human hands simply cannot execute.
That is just wild. It is dynamically dodging blood vessels while it weaves.
Yeah, it's an engineering marvel.
But, as amazing as it is to perfectly install 1,024 electrodes into the lower cortex, the hardware itself is really just a prerequisite.
Oh, absolutely.
Because you can have the best wiring in the world perfectly placed, but if the software doesn't know what to do with the signals, you just have metal sitting in your head.
Exactly. The translation of that electrical noise into actionable digital commands is where this graduates from an engineering marvel to a clinical breakthrough.
Right.
And as of early 2026, the source confirms these trials have expanded to 21 global participants.
Which is a huge step up.
It is. This is building heavily on the initial human implantations that started back in 2024. The core focus right now is restoring digital and physical autonomy for individuals with severe paralysis, like those living with ALS.
And there are two main studies tracking this real-world application, right?
Right.
The first one, the article highlights, is the PRIME study.
Yes, the PRIME study.
That stands for Precise Robotically Implanted Brain-Computer Interface. PRIME is heavily focused on the digital side, translating neural intent into moving a cursor on a screen.
Right, giving them digital agency.
And the SpiralSeekr data states that these users achieved information transfer rates exceeding 10 bits per second for digital cursor control.
Yes, 10 bits per second.
Now, here's where it gets really interesting. I have to stop here because to a layperson, to me, 10 bits per second sounds agonizingly slow.
It does sound slow.
Right. My brain immediately goes to a 1990s dial-up modem struggling to load a single grainy image. Why is 10 bits per second being celebrated as a massive breakthrough?
It is a completely natural reaction. We are so conditioned by consumer electronics to measure success in gigabits and terabytes.
Yeah, exactly.
But we have to change our frame of reference when we talk about biological intent. Think about what a bit actually is in this context. It isn't a pixel of a video stream. It is a fundamental unit of decision.
Okay, so how does that translate to a human experience?
Let's look at you sitting right there. When you reach out and move a standard computer mouse with your hand to click an icon, there is a whole cascade of events.
Right, my brain says move, and my arm moves.
Exactly. Your brain generates the intent, the signal travels down your spinal cord, your arm muscles fire, your hand moves the mouse, and the cursor moves on the screen. If you measure the actual data rate of your intent translating into that physical action on the screen, it hovers right around 10 bits per second.
Wait, really? My baseline speed using a physical mouse with my actual hand is only around 10 bits per second.
Yes. That specific information transfer rate precisely parallels the baseline operational speed of an able-bodied individual using standard physical computer peripherals.
Wow! Okay, that completely changes the context.
It really does, because for someone who is completely paralyzed, achieving 10 bits per second means they have achieved total digital autonomy.
They're moving as fast as anyone else.
Exactly. The implant is reading the motor cortex, decoding the pattern for move up and click, and executing it instantly. They can navigate a screen, type, and interact with the digital world at the exact same speed as someone physically holding a mouse.
It is the complete restoration of digital agency. That's incredible.
It's life-changing.
Okay, but a digital cursor, as life-changing as it is for communication, doesn't help you physically interact with the real world. You can't click a mouse to feed yourself.
No, you can't.
And that bridges us to the second trial, the source outlines, which is the Convoy Trial.
Which is running in parallel with PRIME. While PRIME is strictly digital, Convoy is testing the feasibility of physical autonomy.
Right.
They are integrating the N1 implant with investigational assistive robotic arms.
And we aren't just talking about twitching a robotic finger. The patients in this trial, these are individuals with long-term quadriplegia. They are completing targeted reaching and basic mechanical tasks.
They're feeding themselves.
Yeah. To cross that gap, the interface has to manage physical matter in three-dimensional space. It has to deal with gravity and inertia, all powered by bypassing the damaged neural pathways.
And that is a vastly more complex computational problem. I mean, moving a pixel on a screen doesn't require calculating the weight of a fork.
Right, or the resistance of the food.
Exactly. But because the N1 implant is capturing such high-resolution data from those 1,024 electrodes, the decoding algorithms can extract the highly nuanced intent required to manipulate physical robotics.
But having 21 human subjects utilizing these implants to move cursors and robotic limbs 24 hours a day, I mean, that creates an unavoidable logistical reality.
Oh, the data load.
Yeah, you can't have people permanently hooked into these interfaces without generating a tidal wave of information.
It creates an unprecedented ocean of high-bandwidth objective brain data. And that data is forcing a massive restructuring of the entire systemic medical infrastructure.
Right. The SpiralSeekr piece calls out the introduction of something called continuous neural telemetry as a new standard clinical endpoint.
Yes, continuous neural telemetry.
Which basically just means the automated recording and transmission of data from remote sources. In this case, the remote source is the human brain.
Right.
To understand why this is a complete paradigm shift, you have to think about how medical assessments traditionally work. If you have a neurological condition, you go to a doctor's office, maybe once every 6 months?
Usually, yes.
They run some tests, ask you to perform some tasks, and they write it down. It is essentially taking a single blurry Polaroid snapshot of your brain health twice a year.
If we connect this to the bigger picture, the entire clinical field relies on those traditional periodic assessment scales. But what the N1 implant does is replace that biannual Polaroid with a live 247 high-definition video stream of neurological activity.
Which is wild.
It is. The source is explicit that this high-frequency data provides a totally new alternative for measuring patient outcomes.
But how do we even handle that much data? I mean, if I stream HD video on my phone for too long, the battery drains and the device gets incredibly hot.
Very hot.
You can't have a piece of hardware getting hot inside a human brain. That sounds disastrous.
That is actually one of the core engineering triumphs here. The N1 implant has to perform extraordinary on-chip data compression.
Okay, so it squishes the data down before it sends it.
Right. It cannot transmit all the raw electrical noise it hears because the power required to broadcast that wirelessly through the skull would generate thermal levels that could actually damage brain tissue.
Ouch.
Yeah. So the implant processes and compresses the data locally, transmitting only the relevant spikes of intent. But even compressed, the volume of continuous telemetry from 21 patients is just staggering.
Which means the current medical infrastructure literally isn't built to hold this. You cannot use the filing cabinets and standard databases built for those occasional Polaroid snapshots to store a constant stream of neural telemetry.
Exactly. We need entirely new data handling frameworks for clinical research organizations.
Right.
And that need is rapidly turning this from a niche scientific endeavor into a massive economic engine. The article cites Precedence Research, which projects the global BCI market will reach $13.86 billion by 2035.
Almost $14 billion. That tells you everything you need to know about where this is heading.
It proves that the BCI sector has officially graduated from theoretical research in a university lab. The source refers to this new phase as iterative clinical engineering.
Because the automated neurosurgery works?
Because it works, and because the continuous telemetry provides actionable data, capital is flooding in to establish a competitive baseline. It is driving the broader regulatory and commercial infrastructure necessary for applied neurotechnology on a global scale.
So the pipeline is proven. We have the surgical robot, we have the hardware, we have the data framework, and we have the billions of dollars to scale it up.
We do.
And with all of that foundation in place, Neuralink's ambitions can suddenly expand far beyond just motor output. Up to this point in our conversation, everything, like the PRIME study, the Convoy trial, it has all been about the brain sending a signal out.
Right, an outgoing command.
Taking the intent to move and translating it externally to a cursor or a robotic arm. But the SpiralSeekr piece outlines how the focus is actively shifting towards sensory input and broader communication.
It is the natural expansion of the treatment modalities. The foundation of mapping the motor cortex is laid. Now, they are looking at how to map intent for speech.
Wow.
In fact, the U.S. Food and Drug Administration, the FDA, has actually already granted Neuralink a breakthrough device designation specifically for speech restoration.
Which logically tracks, right? If the electrodes can map the complex neural symphony required to pick up a fork, then mapping the neural firing sequence intended to move the tongue, the jaw, and the vocal cords to form a word is just a different dialect of the same language.
Precisely. It is still an outgoing motor command. But the source mentions another concurrent R&D initiative that represents a profound leap in how we understand this technology.
Oh, the Blindsight
The
Project.
Blindsight Project.
So what does this all mean? Because my mind was completely blown by the mechanism of blindsight.
It's incredible.
The goal of this project is to entirely bypass optic nerve damage. And to understand why this is so radical, you have to think about how vision usually works.
Right.
Light hits your eye, the eye turns it into an electrical signal, and that signal travels down the optic nerve to the visual cortex, which is basically the brain's image processor at the back of your head. Usually, if someone is blind due to nerve damage, medical science tries to fix the eye or repair the nerves.
repair the bridge.
But blindsight abandons the eye entirely.
It does. It represents a fascinating inversion of the interface. Instead of attempting to repair the damaged bridge, the goal is to use the interface to stimulate the visual cortex directly.
The conceptual leap here is just staggering. Instead of the brain generating a signal and sending it out through the implant to a computer, the implant is taking external data, say a feed from a digital camera on a pair of glasses, translating it and pushing it into the brain.
Right.
It is artificial direct stimulation.
And this raises an incredibly important question about the limits of neuroplasticity. We're talking about introducing artificial, localized electrical stimulation directly into the visual cortex.
Yeah, which sounds intense.
It is. The visual cortex has evolved over millions of years to interpret signals specifically structured by the human eye. Now, we are injecting digital code into that space.
How does the brain even know what to do with that? I mean, if I just start pumping electrical static into the back of your head, you don't see a tree, you just get a headache.
That is the core challenge right there. Neuroplasticity is the brain's ability to reorganize itself and form new neural connections. The hypothesis is that if you supply consistent, structured spatial data to the visual cortex through the implant, the brain will gradually learn to interpret those artificial signals as sight.
That is unbelievable.
It highlights that the ultimate goal of applied neurotechnology isn't just creating a fancy remote control. It's addressing profound, systemic sensory and communicative deficits at the root architectural level of the mind.
It really is a massive journey when you zoom out and look at all the interconnected pieces we've just covered today.
It really is.
I mean, we started with the physical necessity of flexible threads to survive a pulsing brain. We looked at a robotic system dynamically dodging blood vessels to weave those threads faster than humanly possible.
Yes.
We saw how the 1,024 electrodes are actively giving 21 patients in the Prime and Convoy trials physical and digital autonomy, essentially matching the 10 bit per second baseline of an able-bodied person.
Which is life-changing on its own.
Exactly. And now we see how that proven pipeline is driving a nearly $14 billion market revolution, forcing new data frameworks and culminating in projects like Blindsight, which aims to literally write digital data directly into human consciousness.
It is a measurable and monumental shift. However, as the source makes clear, it is vital that we remain grounded in the clinical reality.
Well, we can't get carried away.
No. The immediate promise of motor and communication restoration is immense, but the long-term hurdles will dictate the ultimate commercial viability of all this.
Yeah, I don't want us to gloss over the fact that the SpiralSeekr piece explicitly states this isn't a flawless, finished product. Let's make sure we highlight those specific remaining challenges.
Well, the primary concern is long-term efficacy and hardware degradation rates. As we discussed earlier, the environment inside the human brain is highly corrosive to foreign materials.
The brain attacks it.
Right. And while the flexible threads mitigate scar tissue, how the microscopic insulation on those threads holds up against the body's natural defenses over a span of decades is still an actively researched question.
Because nobody wants brain surgery every 5 years to replace a degraded wire.
Exactly. Furthermore, the regulatory adaptations required to safely manage this technology are immense. We touched on the infrastructure needed for continuous telemetry, but the sheer complexities of maintaining high-bandwidth neural data security are totally unprecedented.
And that data security aspect brings us to a final, really provocative thought I want to leave you with today.
Oh, the ethics side of things.
Yeah. The article explicitly mentions that the integration of high-bandwidth neural interfaces absolutely necessitates parallel advancements in something called neuroethics.
Right.
Think about the mechanics we just walked through. If clinical devices are continuously streaming objective, high-frequency telemetry, literally measuring our exact localized brain activity and intent 24 hours a day,
Yeah.
and if future iterations like Blindsight can directly stimulate the visual cortex to artificially generate images in your mind,
Mm.
where exactly is the line between our private internal consciousness and our external digital footprint?
That gets very blurry.
If a machine is capable of writing data directly into your visual cortex, who gets to decide what you see?
It represents the ultimate convergence of biology, technology, and philosophy. When the physical boundary of the mind becomes permeable to a digital infrastructure, the historical and ethical frameworks we have always relied upon to define privacy and human autonomy will have to be entirely reimagined.
It changes everything. Well, thank you so much for joining us on this deep dive. Keep questioning everything, keep learning, and as you go about your day, just remember, the next time you are frustrated by a slow internet connection or a lagging computer mouse, think about the machinery required to fix it. And then take a moment to appreciate the absolute marvel of the biological supercomputer running quietly inside your own head.